Madam, madam.
Hello.
Hello.
Shinju,
Yes, sir.
Yes, sir.
echo వస్తుంది echoing. Why? ఇద్దరు ఒకేసారి ఓపెన్ చేసి ఉంచారు అది.
Yes, sir. I
allow
had
to okay,
my
close
phone.
చేయండి. Yeah.
Close
Close in one.
I'm audible enough.
Yeah, now you are audible. You are at home or in the hospital?
Sir, I'm at home right now. I have to reach hospital.
Okay. After this presentation
I'll go.
or in between presentation?
No, I'll go after presentation only.
Okay.
I could not reach there in time, so I just started from. My voice is clear, no, sir?
Yeah, clear.
Okay.
Anna, good morning.
Anna, good morning.
Yes.
సాటర్డే అంటే మర్చిపోతారన్నా, జనరల్ క్లాస్ లేదనుకుంటారా?
పెట్టావు కదా మెసేజ్.
మెసేజ్ పెట్టాము. ఒక్కోసారి అంటే అది ఏదంటారు కదా, అలవాటు పడతారు థర్స్డే ఫ్రైడేకి. దాని ఎఫెక్ట్ కూడా ఉంటుంది కొంచెం. ఏమన్నా మీకు H3 ఆర్ గెటింగ్ H3 అంటూ
ఏది
H3 అంటూ వస్తున్నాయి క్లాసులు బాగానే.
స్వైన్ ఫ్లూ వస్తున్నాయి. ఇది కోవిడ్ ఉన్నారు ఇప్పుడు 3 కేసులు.
కోవిడ్ వస్తున్నాయి అంట కదా బాగానే ఇప్పుడు.
3 కేసులు ఉన్నాయి నా దగ్గర. అంటే బాగా వైరల్ ఫీవర్ అని చెప్పి సరే మాకు ఇప్పుడు ఫిల్మారీ రొటీన్ చేస్తాం అందరికి. థ్రోట్ స్వాబ్, రెస్పిరేటరీ ఇన్ఫెక్షన్ అంటే ఫిల్మారీ చేస్తున్నాం. కానీ ప్యారలల్ గా H1N1 RT-PCR థ్రోట్ స్వాబ్ పంపిస్తున్నాం కోవిడ్ది. ఫిల్మారీలో మొన్న ఒకడికేమో లీజనల్ పట్టుకుంది, ఒకడికేమో ఇన్ఫ్లుయెంజా బి అన్నది. అట్లాగా ఒకటి దగ్గర ఏం సిమ్టమ్స్ ఇంప్రూవ్ అవ్వట్లేదు ట్రీట్మెంట్ తోటి అని చెప్పి కోవిడ్ RT-PCR పంపిస్తే పాజిటివ్. బట్ అందరికి కూడా ఎక్స్రేలో ప్యాచ్లు ఉంటున్నాయి, సిటీలో ఎక్స్రేలో జీజీఓస్ ఉంటున్నాయి. బట్ టిపికల్ మన పాత కోవిడ్ ప్యాటర్న్ పెరిఫరల్లీ ప్లేస్డ్ క్లోరల్ బేస్డ్ లేషన్స్ అట్లా లేవు. డెన్స్ కన్సల్టేషన్స్ ఉంటున్నాయి. లెఫ్ట్ లోయర్ జోన్ లో ఒకటికి, రైట్ లోయర్ జోన్ లో ఒకటికి డెన్స్ కన్సల్టేషన్స్. ఇద్దరు ఓల్డ్ ఏజ్, ఆల్మోస్ట్ రెస్ట్రిక్టెడ్ టు హోమ్ ఓన్లీ. 92 ఒకడు, 94 ఒకడు.
వెంటిలేటర్ ఎన్ఐవి.
ఒక పేషెంట్ ఏమో డిఎన్ఆర్ ఇచ్చేసారు 94. సో ఎన్ఐవి వరకు వెళ్ళాము, తర్వాత డెత్ అయిపోయాడు.
94 years.
94 years. ఇప్పుడు 92 ఈజ్ 2 liters ఆక్సిజన్ తో స్టేబుల్ గా ఉన్నాడు. ఇవాళ 5th డే ఆఫ్ రెమ్డెసివిర్.
92, 94. కూడా ఉన్నాయండి వైజాగ్ లో 5-6 కేసులు వచ్చినాయండి.
అంటే మనం టెస్ట్ చేయట్లేదు, చేస్తే దొరుకుతాయేమో. అది
అదే ఆ మధ్య చేసినా కూడా దొరకలేదు.
ఇప్పుడు దొరుకుతున్నాయి.
ఇప్పుడు దొరకచ్చు. అది మళ్ళీ సీజన్ కొంచెం
అది.
హలో
మేడం, షల్ వి స్టార్ట్?
మార్నింగ్ డేవిడ్, అదే శ్రీనివాస్ జాయిన్ అయ్యాడా? శ్రీనివాస్
మేడం, గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్ శ్రీనివాస్.
మార్నింగ్ శ్రీనివాస్, ఇంట్రడ్యూస్ చేస్తావా? అది సింజూని ఇంట్రడ్యూస్ చేసి స్టార్ట్ చేస్తారా? డేవిడ్, కెన్ వి స్టార్ట్?
Yes, madam. Good morning, all of
ఓకే
you.
చాలా స్లైడ్స్ ఉన్నాయి.
Yeah.
ఓకే
Dr.
మార్నింగ్ డాక్టర్ శ్రీనివాస్ అండ్ రాణి మేడం.
మార్నింగ్ మార్నింగ్.
Sindhu, you put it in a slideshow.
Yes, sir.
Yeah. Dr. Sindhu is going to talk on weaning. I request Dr. Monang Srinivas to introduce Dr. Sindhu.
Good morning. So Dr. Sinju will now be presenting regarding the role of ultrasound in weaning, and after that we will restrict our discussion and questions only for ultrasound part per se, and not for the whole weaning. Okay, so this might be the last class for Sinju from Care Hospital, and as she is completing her tenure and as she has given her IDCCM exam, so waiting for the result. Okay, all the best, Sinju.
Thank you, sir. So, good morning, everyone. My topic is on weaning, current approach to weaning using ultrasound. So weaning itself is a component of liberation, which is a three-step process: readiness testing, weaning, and extubation. Readiness testing is making use of objective clinical criteria and physiological tests to determine whether a patient is ready to begin weaning from mechanical ventilation. Weaning is the process of decreasing the degree of ventilator support and allowing the patient to assume a greater proportion of their own ventilation. And extubation is the removal of the endotracheal tube, and it's the final process of liberation from mechanical support. So weaning criteria, it is based upon three: ventilatory criteria, oxygenation criteria, and pulmonary reserve and measurements. So ventilatory criteria is based upon PaCO2 when the PaCO2 is less than 50 mmHg with a pH of more than or equal to 7.35 with a vital capacity of 10 to 15 ml per kg. When patient is having a spontaneous tidal volume of more than or equal to 5 to 8 ml per kg with a spontaneous rate or respiratory rate of less than 30 per minute and a minute ventilation of less than 10 liters per minute. Oxygenation criteria, PaO2 without PEEP of more than 60 mmHg with at FiO2 up to 0.4 and PO2 with PEEP of more than 100 mmHg at FiO2 up to 0.4 and an SaO2 of 90% at FiO2 up to 0.4 and PF ratio of more than 200. In pulmonary reserve and measurements, we measure the maximum voluntary ventilation, which should be at least more than 2 times the minute ventilation at FiO2 up to 0.4 and maximum inspiratory pressure of at least minus 20 to minus 30 centimeters of water. And pulmonary measurements like static compliance should be at least more than 30 ml per centimeter of water. So the methods of weaning, what are the methods which we employ? Either we can use spontaneous breathing with TPs or pressure support ventilation, or in earlier times which were used was SIMV with pressure support ventilation with progressive decrease in the SIMV rate. Now, SIMV as a standalone weaning modality should not be used. And this can be, and later on, depending upon the depending upon the objective as well as subjective measurements, we can try and wean the patient or extubate the patient. Objective measurements would consist of PO2 of less than 50 to 60 mmHg, on FiO2 more than 0.5, or SaO2 if it is decreasing to less than 90%, PaCO2 if it is increasing to more than 50 mmHg or increased by 8, pH if it is falling less than 0.32, or an RSBI, that is rapid shallow breathing index, which is a measure of respiratory rate divided by the tidal volume in liters if it is more than 105, and the respiratory rate if it is going above 35 or an increase by 50%, and heart rate of more than 140 per minute or an increase by 20% from the baseline, or the systolic blood pressure of more than 180 mmHg or an increase by 20%, and systolic BP of less than 90 mmHg, or presence of cardiac arrhythmias. Subjective measurement criteria, which would include subjective measurement criteria, which includes agitation, anxiety, depressed mental status, diaphoresis, cyanosis, evidence of increased efforts and increased use of accessory muscles, and facial signs of distress and dyspnea. So in case these objective and subjective criteria are present, we have to hold on weaning. And in case of the absence of all these criteria, we go ahead with extubation, provided there is good patency of airways, patient's mental status is good, a patient has a good GCS about 10, and secretions are minimal, and positive cuff link test is there, and patient has a good cuff strength, which is measured using cuff peak expiratory flow of more than 60 liters per minute. And in the absence of any pending radiological or surgical procedure, we go ahead with extubation. Now, in case of failed spontaneous breathing trials or reintubation or death, which occurs within 48 hours of extubation, we call it as weaning failure. Weaning in progress when the patient is extubated but onto an IV. And it's called as difficult weaning when the patient who fails initial attempts of weaning up to 3 SBTs, or as long as 7 days are required from the first SBT to achieve successful weaning. Prolonged weaning when the patients who fail more than 3 attempts of weaning and require more than 7 days of weaning after the first SBT attempt. As per the latest incidence is estimated to be 20 to 25% of weaning failure in all patients who are put on mechanical ventilation. So here is a graphical, diagrammatical representation of patients who've been given of SBT trials, and the definition of difficult weaning, simple weaning, and prolonged weaning has been explained on this diagram. If after first SBT itself, patient can be safely extubated, it is called a simple weaning. If the patient requires up to 3 attempts of weaning or SBTs for a successful weaning, it is called as difficult weaning. And more than 3 SBTs, it is called as extubation. More than 3 SBTs and more than 7 days from the first SBT would be labeled as prolonged weaning. So in case of difficult weaning or prolonged weaning, we can prophylactically make use of NIV in COPD patients. Or in case if the patient is requiring longer stretch of time, then it is called as permanent weaning failure, in which case we have to transfer the patient to a weaning center or employ home mechanical ventilation. Etiology. Now we'll discuss about the basic reasons which underlies the respiratory muscle fatigue. It can respiratory muscle fatigue can happen either because of decrease in the muscle strength or increase in the muscle demand. So this can happen either because of underlying malnutrition or dyselectrolytemia, that is hypocalcemia, hypomagnesemia, hypokalemia, hypophosphatemia, and either because of cardiovascular dysfunction or ischemia of the respiratory muscles or the use of sedative drugs and delirium, in which case we have to treat it with treat the delirium and come down on the sedative drugs and do cognitive stimulation and early mobilization. Decrease in the muscle strength can happen because of ventilator-induced diaphragmatic dysfunction and also because of underlying hypothyroidism, in which case we have to correct it. Acetoacetamide has also been used as one of the methods to expedite the bicarbonate excretion and bring down respiratory acidosis. And as a respiratory stimulant, medroxyprogesterone acetate can also be used. But all these are unproven and are not routinely employed in order to expedite weaning. Increase muscle demand, as in a case of underlying infection and uremia. And in asthmatics, if there is underlying bronchospasm, we can correct it with bronchodilators. And in patients who are having pulmonary edema, myocardial ischemia, and any kind of cardiac dysfunction, this can be sorted out by means of diuretics and CPAP. And if there is any underlying pleural effusion that needs to be drained out in order to facilitate weaning. So out of all these, we are going to concentrate upon the highlighted ones, that is the ventilator-induced diaphragmatic dysfunction, the pulmonary edema, cardiac dysfunction, and pleural effusion, which is something which can be readily made out using day-to-day modality tool, that is our USG tool, and which would help us in facilitating weaning process, where we can employ the point of care. So let us focus upon the utility of the POCUS in weaning. So weaning failure can happen either because of pump failure or because of lung failure. So pump failure, it is said that if the left ventricular ejection fraction, if it is less than 40%, it is associated with high probability of weaning failure. If the mitral wall inflow with E wave, which is measured using E wave and A wave, and estimated using the pulse wave Doppler for estimating diastolic dysfunction and filling pressures, the E/A ratio, if it is more than 2, it is estimated with a high. It is estimated to have high probability of weaning failure. Likewise, mitral valve annulus, when we do tissue Doppler estimation, image estimation for left ventricular relaxation, and which is quantified by E prime ratio. If it is more than 14, it is associated with higher probability of weaning failure. Likewise, cardiac output. If the cardiac output is augmented after giving a passive leg raise test with measurement of left ventricular outflow tract or using VTI or pulse wave counter-evaluation, then it again helps us in estimating whether the patient is in impending cardiac pulmonary edema. POCUS can also be used to diagnose lung failure, and which can be estimated by measuring the diaphragmatic thickness fraction, and measuring the peak inspiratory amplitude of diaphragm, and estimation of the pleural effusion, and quantification, and thereby therapeutic as well as diagnostic evaluation and quantification of aeration score. So we're going to discuss each of these topics one by one from here on. So before delving into the concept of pulse wave Doppler, let's understand the basic concept of diastology. So diastology, which is very well depicted in this diagram. We know that left ventricular volume, the left ventricle during diastole, it undergoes 3 phases. That is the phase of rapid filling, phase of diastasis, and the phase of atrial kick. So in this phase of rapid filling, as soon as the mitral wall opens, it would cause passive filling and passive filling of the left ventricle from the left atrium, and the blood would flow passively without any active contraction. And then there is the phase of diastasis, where there is no active flow of blood, which is followed by atrial kick, which is followed in which there is active contraction of the atrial muscles, which would further cause filling of the left ventricle. So corresponding to the rapid filling, we have left ventricular velocity, which is represented by E wave. And corresponding to the atrial kick, we have A wave. So these are the E wave and A wave are the 2 parameters which we're going to measure using pulse wave Doppler in the subsequent slides. So in pulse wave Doppler, we try and obtain an image of a apical 4-chamber view by using a cardiac phased array probe, which is kept at 5th intercostal space. And then we direct the beam towards the right shoulder and try to get a 4-chamber view. And we take out a pulse wave Doppler and put the pulse wave Doppler sampling gate just in front of the opening of the mitral valve, and activate the graph by pressing on the Doppler button. By activating the graph, we get an image which is shown on the left-hand bottom corner here, and this would be corresponding to the S wave in that is a negative deflection. And this the positive deflection which follows the S wave is labeled as the E wave, the E wave velocity. And the very next wave, which is the positive deflection following the E wave, is called as the A wave. So as depicted in the earlier slide, the E wave and the A wave, which represents the left ventricular blood flow velocity across the mitral wall, can be measured out by using the calipers, which is dropped from the baseline up to the peak of or the amplitude of the E wave and A wave respectively. So it is this pulse wave Doppler helps in integrating the flow across the mitral wall. So the pulse wave of mitral wall inflow, this is the kind of image which we get on our SonoSight machines. And here on the left-hand side, in the left-hand side, you would get a display of the E wave velocity, which is calculated when you do the caliper measurements from the baseline to the top of or the peak of the amplitude in either E wave or A wave. And it helps in estimating the E wave and A wave velocity, which is 89.6 centimeter per second in this case and 51.8 centimeter in the case of A wave velocity. And we measure the E by A ratio in this slide. And that can be manually calculated, or otherwise some machines come up with the software which can actually calculate and let us know about the ratio. So this, how does this help, this E by A ratio? Suppose this E by A ratio, it is less than 0.8, then the left atrial pressure is likely to be normal. If this E by A ratio, if it is more than 2, the LAP, the left atrial pressure, is likely to be higher. And the E by ratio, if it is somewhat in between 0.8 to 2, it is said to be indeterminate, but still we can estimate or quantify this. If the values which are closer to 0.8, it is said to have normal LAP, and whereas a value which is closer towards 2 would have a higher left atrial pressure. Likewise, we can also estimate the tissue Doppler imaging. That tissue Doppler imaging, as the name suggests, tissue, we are finding out the movement of the mitral, the movement of the myocardium, that is the left ventricular myocardium, during diastolic phase. And it can be estimated by putting the tissue Doppler. It's not the pulse wave Doppler, it is the tissue wave Doppler, which is kept across the mitral wall insertion point, either at the medial end of the mitral wall or at the lateral end of the mitral wall, which is depicted here. So in either of this case, if you employ this tissue Doppler image and activate the graph, what we get is somewhat like this. And here you would be able to see the movement of the left ventricular myocardium in systole as well as in diastole. So here this systolic contraction, which is the movement of the myocardium towards the probe, and hence it has a positive deflection. So the S wave, which comes as above the baseline, is having positive deflection, and that's the reason when it is actively contracting towards the probe, it comes up as a positive S wave. And the next very negative deflection which follows is the first early rapid filling phase, in which the left ventricle undergoes relaxation. And the very next wave which follows that is again the further relaxation of the left ventricle, which shows, which corresponds to the atrial kick phase. So here we estimate the E prime and the A prime. E prime, which would be estimated by dropping in caliper from the baseline to the peak of the amplitude, and then what we measure would be labeled as the E prime, and which gets displayed onto the left-hand corner of our screen. That is 10.2 centimeters per second in this case. So how is it helpful? So we are comparing the two graphs, which is obtained from pulse wave Doppler and the tissue Doppler. So the pulse wave Doppler, which represents the blood flow across the mitral valve, so it is estimating the velocity of the blood flow across the mitral valve. And here there is a pictorial representation of E wave and the E wave velocity, which is seen. If there is increase in the left atrial pressure, the E wave and the E wave keeps on progressively increasing. Correspondingly, if there is in the early diastolic phase, if the ventricles are relaxing, and there is progressive diminishing in the relaxation of left ventricles, this would cause decrease in the length of the E prime, which is depicted by the below diagram. And you would see the E prime, it is progressively showing decrease in the length. And if you estimate the E by E prime ratio, there would be increase in the ratio, and this would represent progressive diastolic worsening. So in this, we can, if we are able to estimate this E by E prime ratio, and if it is found to be less than 8, it is said to have a normal left atrial pressure. And if it is more than 14, it is said to have an elevated left atrial pressure. And if it lies somewhat in between 8 to 14, it is said to be indeterminate. For the USG nerds out there, it can even be estimated using NAGWA formula, which is given by left atrial pressure, which is equal to 1.24 times the E by E prime plus 1.9, or a simplified version to this is E by E prime plus 4. So this gives us a rough estimate of the left atrial pressure. So let us understand this in with respect to a case scenario. Here we have a 53-year-old female with an old history of coronary artery disease and a poor ejection fraction. We had a case of post-operative laparotomy for bowel perforation, and it was day 3 of post-operation, and we had given her a spontaneous breathing trial. And after 3 hours of spontaneous breathing trial, there was worsening hypoxia, which was seen on ABG, and the chest X-ray which was taken had new infiltrates, which had this confounding findings, which were fitting into both the pictures of ARDS versus cardiogenic pulmonary edema, and the vitals were like this. And the patient was again connected to the ventilator, and FiO2 was started again with 48%, and PC of 8 was started with a PEEP of 8. The thoracic scan, which was done afterwards, had shown confluent B lines. Actually, it is said that if with adequate expertise in the thoracic scan, one can even diagnose ARDS or cardiogenic pulmonary edema by looking at the pleural lines. If the pleural lines are like coarse and thickened, it would moreover be consistent with ARDS findings. If it is thin and uniform, it would be moreover consistent with pulmonary edema. But these findings are subjected to intraoperative variability, and which is the reason why we have to go by more subjective measurements like pulse wave Doppler. So if we employ pulse wave Doppler in this case, we find out that by dropping in the Doppler gauge just across the mitral valve after obtaining a 4-chamber view and activating the graph, we will get an E and A wave velocity, which is displayed on the right-hand side corner of this screen, which is 77.28 and 106 respectively. And when you take out the E by A ratio, this would be somewhat closer to 0.73. So if this ratio is less than 0.8, as depicted earlier in the earlier slides, you would conclude that the LAP is normal. Likewise, we can do a confirmatory measurement using tissue Doppler imaging by dropping this Doppler gate at the insertion of the mitral valve at either medial side or the lateral side, and you would get an E prime. The E prime, which as earlier explained, it corresponds to the relaxation of the left ventricle. So if the velocity is given here as 11.61 centimeters. So by calculating the E velocity from this and E prime from this, this comes around 6.66, the ratio. And likewise, the it is rather advised to get an average between the E prime, which is obtained from the tissue Doppler imaging from medial and lateral E by E prime, and this comes at around 5.87 in this case. So the ratio is somewhat showing that it is less than 8, and in which case, again, the left atrial pressure is confirmed to be normal. So this patient doesn't have any impending cardiogenic pulmonary edema. It's a pure case of ARDS, and which could be due to any ventilator-associated pneumonia in this case. So let us understand this in terms of weaning-induced pulmonary edema. The mechanisms which is involved in weaning-induced pulmonary edema is there is sudden inspiratory fall when you take the patient out of mechanical ventilation to spontaneous breathing. There is the positive pressure ventilation, which was given with the help of mechanical ventilator, is being removed, and there is sudden fall in the inspiratory pressure, intrathoracic pressure, which causes a surge in the catecholamines discharge, and this would result in increase in the systemic venous pressure gradient and the increase in the left ventricular afterload and left ventricular preload. So in a patient who is having pre-existing right ventricular dysfunction, as in COPD, there would be right ventricular dilatation with dynamic hyperinflation or intrinsic PEEP. There can be further dilatation of the right ventricle, which, because of interventricular dependence, would push the interventricular septum towards the left ventricle, causing further decrease in the left ventricular filling, or left ventricular diastolic filling would be compromised in such case, and output would be reduced. So the left ventricular compliance is decreased in such cases. And there would be increase in the diaphragmatic activity and increase in the use of accessory muscles, which would contribute towards increased work of breathing. And altogether, when the myocardial oxygen demand is increasing, which is not met with the supply, there can be myocardial ischemia, which is expected in such cases, which is manifested as dyspnea, anxiety, and decrease in the gaseous exchange. So here we have a diagrammatic depiction at the alveolar level. So what we can see is there is exudation of the intravascular fluid from the intravascular compartment into the interstitial compartment and then into the alveoli, which fills up the alveoli. And these protein molecules being much larger in size, it gets retained inside the vessels, and therefore this is what contributes towards the hemoconcentration. So the hypooncotic fluid gets transmitted across the alveoli, and this would fill up the alveoli, and this would contribute towards the pulmonary edema at the alveolar level. So hemoconcentration can also be used as a measure for estimating weaning failure in certain cases. Coming to...
Okay, I found this on the web for estimating weaning failure in certain cases. Check.
So velocity time integral. So velocity time integral, since we are dealing with cardiac dysfunction, which can be estimated, which can be in terms of both systolic dysfunction as well as diastolic dysfunction. So we are supposed to measure the velocity time integral. We are supposed to measure the cardiac output using velocity time integral, and the blood flow across the left ventricular outflow tract during systole would help us in estimating the systolic dysfunction. And knowing when velocity time integral, if we assume that the left ventricular outflow tract cross-sectional area is constant in either cases, then the velocity time integral would correspond towards the stroke volume. And the normal range in which case, in this case, would be closer to 18 to 22 centimeters. After passive leg raise maneuver, if there is an increase in the VTI by 12%, then such patients are said to be fluid responsive. So how do you go about estimating velocity time integral? So velocity time integral is something which we are very well versed with. We use this cardiac phased array probe at the apical region along the mid-clavicular line in the fifth intercostal space, and we try to obtain a four-chamber view by directing the beam towards the right shoulder. We fan out the beam in such a way that we obtain a five-chamber view. So in that five-chamber view, when the aortic wall or the left ventricular tract is available, we make use of, we drop in the Doppler gate just across the left ventricular outflow tract and activate the graph. So this before estimating VTI, we have to keep in mind two things. One is that the Doppler gate has to be within 20 degrees of the aortic flow, the blood flow across the LVOT. And second thing is the septum needs to be as perpendicular to the probe as possible. So when you activate the graph, the tracings would resemble something like this, which is given at the bottom. So you can make use of the caliper on the keyboard and try tracing out the outer ends of the graph from one end to the other. And when you use the select button, or the values which are displayed on the left-hand corner of the screen would give you a value of velocity time integral in this case, like it is around 19.7 centimeter in this case. So, okay. So we have to measure this velocity time integral in terms of passive leg raise. That is, after making the first, you make the patient semi-recumbent and then obtain the VTI. And after just 2 minutes of making the patient supine, you raise the legs to 45 degrees passively. That is using the bedside remote control. And then at the same spot, you are supposed to measure the LVOT VTI. And if there is these two graphs which we have obtained needs to be compared. And if there is increase by more than 12%, that is when you call it as the patient would be like fluid responsive, or even if the value is less than 12%, we can say the patient is having impending cardiac pulmonary edema. And in such cases, we cannot stress the patient with weaning, because weaning in itself is a stressful procedure. So let us understand this with this second case scenario, which is given here. We had an elderly male who was in sepsis with pulmonary source being the primary. And he also had a past history of congestive heart failure with poor ejection fraction. The patient had recovered from sepsis, and therefore spontaneous breathing trial was given, which failed, unfortunately. And therefore, we did a cardiac output estimation using PLR by employing this VTI technique. This can also be done using Simpson method. And the lungs on examination was showing diffuse B lines. But again, it is confounding. So we have to try and estimate the VTI in such cases before PLR and after PLR. So we dropped the Doppler gate across the left ventricular outflow tract and measured the VTI. We measured the VTI before PLR, and it was close to 13.6. And after PLR, this was close to 15 centimeter. It was close to 14.9 centimeter, and the ratio, the proportion came out, the difference came out to be less than 12%. It is around 10% in this case, and therefore the patient was estimated to be unfit for weaning because the patient was having impending cardiogenic pulmonary edema. The slide explains something which I have already explained before. That is, the patient, there are certain pitfalls with using VTI as a sole parameter, because the Doppler gate needs to be within 20 degrees of the outflow tract. Secondly, the Doppler gate needs to be in the same spot in the LVOT for both the VTI measurements, and there can be intraoperative variability. Now, coming to the estimation of ejection fraction. Ejection fraction can be estimated either by eyeballing technique, which is a qualitative method of assessment, or by Simpson's method, and thirdly, by fractional shortening assessment. So we're going to deal with it one by one. So in order to understand the ejection fraction, one should be very well versed with this Plaque's view. So how to obtain a Plaque's view? Using a cardiac phased array probe, which is kept at the 3rd to 5th intercostal space, and you fan out the view using the probe, and in the downward direction, the beam would show or depict right ventricle from top to bottom, left ventricular outflow tract, and the left ventricle, the mitral wall. and the left atrium. So this would somewhat come closer to this diagram, which is displayed on the right-hand side corner. So this is by eyeballing technique. It's obtained from the plaques view. The top side one corresponds to the right ventricle, the left ventricular tract, and those and here we have left atrium and the left ventricle, which is displayed, and the mitral valve, which opens up during during systolic ejection, would help us in estimating the ejection fraction. So how do you do it by an eyeballing method is that we the circled one, the yellow circled one, is the anterior mitral valve leaflet. So this there is the tip of this mitral valve leaflet is called as the E point. So this E point, when it beats against the anterior wall of the interventricular septum, if it comes very much closer, it's called this distance would be measured in terms of E point septum separation, that is EPSS. So if it comes very much closer and the distance is short, we say that the ejection fraction is really good. And if it doesn't, if the EPSS movement is less or it has wider separation, it is said to have lesser ejection fraction. Now coming to the myocardial thickening. So during during contraction of the left ventricle, you would observe that there is fractional shortening of the myocardium, or there is reduction in the myocardium by 20 to 25%. And as it undergoes contraction, the myocardial wall undergoes thickening. So these and all can be estimated visually. And again, it's a subjective measurement. If you want to go for more quantitative measurements, we go for Simpson method. So the Simpson method, it can be easily estimated by using cardiac phased array probe. Again, it's a low frequency probe. We keep it on fifth intercostal space along the mid-clavicular line. And we obtain a 4-chamber view. This 4-chamber view would show all the four chambers, that is the left ventricle, right ventricle, left atrium, right atrium. And we measure the volume of the left ventricle at the end of diastole as well as systole, and detect the changes in the cavity size and estimate the ejection fraction, which is given by this formula. That is end diastolic volume minus the end systolic volume divided by end diastolic volume multiplied with 100. Now, how do you go about it is you freeze the graph, you freeze the 4-chamber view and scroll across and obtain the points where there is maximum dilatation that would correspond to your 4-chamber view in diastole, and minimum and maximum contraction, which would correspond to the minimum area, which would depict apical 4-chamber view in systole. So these two graphs, these two areas can be estimated by making use of caliper. We try and trace the graph by going about the inner borders of the myocardium from one end of the mitral valve annulus all the way around up till the next point, back to the end of the mitral valve annulus. And on activating the select button, you would get a value which is closer to 28.4 centimeters square here in this case. And then similarly, you save this, save all this data and go about selecting and estimating the area for systolic view, that is in the systolic 4-chamber view, by repeating the same method. That is, from one end of the mitral valve, you go about tracing the area from the inner side of the valve, and again estimate this area, and then on pressing the select button, it would show an ejection fraction, which is automatically calculated by the machine itself. And this would correspond to, in this case, it is found to be 63%, which is as displayed on the left-hand side corner. Now, in the plaques view itself, if you want to estimate the ejection fraction, this is something which is usually employed by the echocardiographers. And you would see the M mode has to be activated beyond the point of mitral valve opening. And as depicted by this colorful diagram, this the blue portion would correspond to the right ventricle, when you activate this M mode, and right ventricle lumen, which corresponds to the yellow portion, and the interventricular septum, which is displayed by the red portion, and left ventricular lumen, which you can see by the green portion in the respective diagrams, and left ventricular posterior wall is something which is which corresponds to this purple portion. So when you activate the graph, you can measure the volume, the lumen volume of the ventricle in systole as well as diastole. So here, the sinusoidal wave patterns, you are able to see the sinusoidal wave patterns with peaks and troughs. The peaks would correspond to the systolic phase, and the troughs would correspond to the maximum depression that is corresponding to the diastolic phase. So you can drop in a caliper from either end, and this would help in measuring the left ventricular lumen size. And if you enter all this data onto the USG machine, it would automatically generate the ejection fraction. So this method is also called as fractional shortening, which is obtained from the Planck's view. So we understood that this weaning-induced pulmonary edema is something which is treatable. So either in terms of diastolic dysfunction or in terms of systolic dysfunction. So if there is a diastolic dysfunction, we can treat it using diuretics if there is increased preload. If there is increased afterload, use nitrates. If there is increased systolic blood pressure, we use nitrates. Likewise, systolic dysfunction, if it is there, we can use beta-1 agonist, that is dobutamine. But dobutamine, as such, we saw that ventilator-induced pulmonary edema is having is because of the increased catecholamine surge, and on top of it, if you're giving beta-1 agonist, this can further increase the myocardial oxygen demand. And it is rather said that it is better to avoid it. And likewise, inoximone, which is a newer phosphodiesterase inhibitor, and which does vasodilatation and can be made use of in weaning-induced pulmonary edema. And likewise, if hypertrophic cardiomyopathy is there, we can use calcium channel blockers and do appropriate settings of the ventilator and make use of appropriate modalities in order to treat ventilator-induced pulmonary edema again. So again, we can measure we can also measure this lung failure in terms of diaphragmatic thickness and atrophy. So diaphragm undergoes atrophy with increase in the duration of the mechanical ventilation. There can be waterlogging because of collection of collection of water in the diaphragm, either because of pleural effusion or ascites, or because of concomitant infection, which would further cause increase in the length of stay in ICU and increase the complication rates. It is estimated that the thickness of the diaphragm reduces by 6 to 7% per day in adults and 3.5% per day in children. So how to make use of ultrasound probe in estimating the diaphragmatic excursion, peak inspiratory amplitude, the thickness and thickness fraction, we're going to see in the coming slides using curvilinear probe. So the diaphragmatic excursion, which can be made use, which can be detected by using this curvilinear probe. This curvilinear probe, which is kept at the mid-clavicular line in the subcostal region. If one finds it difficult to visualize the diaphragm, here the glistening structure which is seen over here is the diaphragm. On the second diagram, that is the B diagram, and this diagram shows diaphragmatic excursion. So you would be able to see that with the movement of the diaphragm during inspiration is in the downward direction, that is said to be normal. that is caudate direction, is said to be normal. And if it is in the cephalad direction during inspiration, it's said to be abnormal. So this is very well depicted in this diagram, where during inspiration it moves down and during expiration it moves up. So if you activate in M mode, the graph which is generated would correspond to something like this. So this is during normal tidal breathing, and you can ask the patient to actively do deep inspiration, and there would be elevation in the graph. Here, when you activate the M mode, the two things which you would obtain at the end of inspiration and the end of expiration is something like this. So at the end of expiration, at the end of expiration, the graph corresponds to the C line. At the end of inspiration, the graph corresponds to B line. And the width between the two, that is B to C, can be calculated using a caliper. And if this distance is somewhat more than 11 to 13 centimeters, 11 to 13 millimeters, it is said to have a good weaning success. And if it is less than 11 millimeter, it is said to have a decrease or a worst case of weaning. Now, we can also estimate the diaphragmatic thickness in terms of the measurements which is obtained at the zone of opposition. So this zone of opposition is a layer which is sandwiched between the parietal pleura and the parietal peritoneum, and the thickness would be measured by using linear probe. And once you estimate once you get the measurements at the end of expiration, at the end of inspiration, we can get the thickness difference by measuring the calipers, by making use of the calipers in each of these cases, and we'll be able to estimate the diaphragmatic thickness difference, and that is given as DTD in this case. And the fraction of thickness fraction of diaphragm is estimated using DTD by diaphragmatic thickness at the end of expiration multiplied with 100. And if this thickness fraction is less than 20%, it is associated with diaphragmatic dysfunction. And if this value corresponds to more than 30 to 36%, it is associated with higher success, higher rate of weaning success. One can also estimate the pleural effusion. See, pleural effusion is something which causes atelectasis and collapse, and it causes decrease in the lung compliance in terms of both static and dynamic compliance. It causes decoupling of the intercostal and diaphragmatic recoil from the underlying visceral pleural surface. And therefore, the removal of moderate to large quantity of pleural fluid is associated with higher rates of weaning success. And likewise, removal of small to moderate pleural fluid is associated with insignificant, if it is associated with the insignificant amount of respiratory compromise, there is lower probability of weaning success. Now, pleural fluid effusion can be estimated by making use of this quad sign or sinusoid sign. We can estimate the height and depth in each case, and this height plus depth multiplied with 70 would give us a rough estimation of the pleural fluid. And in order to make sure if it is safe enough to undergo diagnostic and therapeutic puncture, we can have an estimation of the diaphragm of the expiratory thickness at the trough, at the maximum trough level. If it is more than 15 mm, it is said to have a higher rate of removal of the pleural fluid with in a safe manner. So if there is more than 15 mm of trough level, it is estimated to have better removal of pleural effusion. This quadrilateral sign, this is the quad sign, which is depicted, the four sides of which are represented by the parietal pleura, visceral pleura, and the two sides by the rib shadows. Here, we can also quantify the aeration loss in terms of this score. In terms of this score, which is a 4-tier score, here we have the score ranging from 0, 1, 2, 3. The 0 corresponds to the A lines, 1 corresponds to the multispaced B lines, and 2 corresponds to the coalescent B lines, and 3 corresponds to the subpleural consolidation with confluent B lines. So this score was very much used during COVID times. This aeration deaeration score, which can be quantified by making use of this table. And if it is found to be less than 13, it is associated with higher probability of successful weaning. And if it is more than 17, it is associated with a higher probability of weaning failure. And if it is between 13 to 17, it is associated with indeterminate. It is indeterminate in estimating the likelihood of weaning success or failure. And at the end, I would like to conclude with the biomarkers for weaning assessment, which is something which is newly come up. Here, there are 2 biomarkers, that is the suppression of tumorigenicity 2, that is ST2, which is a member of interleukin-1 receptor family, which is helpful in estimating the cardiovascular stress and inflammation. This helps in guiding the ventilator management and point towards underlying lung injury. So there are certain digital biomarkers which have been developed by the Korean researchers. It is a state-of-art chip-based technology, and it enters the biosignal data, which is quantified in terms of standard deviation ratio between short-term and long-term heart rate variability, sample entropy of EEG, and photoplethysmogram, and respiratory impedance. So when the patient is on SBT ongoing trial, the ventilator itself measures these digital biomarkers and helps us in estimating whether the patient would have a successful weaning attempt or not. That's it. Thank you. That's all about lung failure and pump failure.
Yeah, thank you, Shinju. Very nice presentation. Explained everything. Weaning failure. I request Dr. Monanga to continue the session.
Sir,
Monanga? Yeah.
Sir, session is open for the questions. And
Yeah. Yeah, with my question to Shinju, you explained about VTI, velocity time integral for this PLR test. What about stroke volume variation? Is there any difference between the 2 or the same?
So stroke volume variation can also be done, but our focus was moreover on the USG modalities.
USG modalities also we can estimate the stroke volume by using VTI, the formula pi r
Yes,
square h. Yeah,
yes, sir. Yes, sir. Definitely, sir. I actually said it in the beginning. I'm trying to estimate the VTI in terms of stroke volume itself, but I'm considering that the LVOT tract remains constant in this case. And yes, definitely, we can estimate the cardiac output with the formula that LVOT pi r square. We can find out the area of the cross section and the blood flow velocity across it. And yes, but it is more refined. Yes, you can say that it is more refined.
Thank you. Any questions?
Congratulations, Sinju. You did a good class. And only that's all is very dangerous, because what else is there? Everything you have told. And very nice. And Monanga, you prepared very nicely.
Thank you, sir.
thank you, sir.
Nice one, Sinju.
Yes.
Yeah,
When are you completing
Yes,
your Srinivas?
Sir,
Yes.
చెప్పలేదు సార్
సింజుని ఎప్పుడు జాయిన్ చేసుకుంటున్నావు?
మీరే చెప్పాలి సార్.
ఎప్పుడు అయిపోతుంది?
ఈ మంత్ లో అయిపోతుంది.
Yeah, Varalakshmi wants to ask. Varalakshmi?
Yes, ma'am.
Hi, Sindhu. Great class. I want to know, are there any studies on the validity of all these techniques that you told us? How valid are they?
Ma'am, these are all subjective measurements. The quantification, I mean, in terms of validation, like it is not something which is foolproof. I cannot actually comment upon this. I have done the study based upon, I got this inspiration from one of the articles which was given from the journals of Higgs. So it's a study which was done by, I mean, it's a, it is just a calculated, estimated studies which were done on these, and it's not foolproof. It's not something which we can like extrapolate and employ in day-to-day life. I think these studies are subjective measurements.
Rani madam, మీరు కొన్నారు పుస్తకం అదేనా?
Srinivasa would be better able to explain this.
Ma'am, Varalakshmi ma'am, good morning. Hello.
Hi, Srinivas.
See, for weaning induced pulmonary edema, the gold standard will be the PA catheter related measurement of LFS. No other modality can replace a PA catheter because it is an invasive thing. As we can't put an invasive catheter in all cases. So the best modality, the alternative modality, what we are having at the present with little but a good learning curve, like a longer learning curve with little complication is this modality. So there is no as such comparative studies comparing with the PA catheter and ultrasound guided distance. So whatever the studies have been done, it is done with non-PA catheter things like stroke volume variation from an arterial line or EV 1000, all those things. But as such, there is no direct comparison with the PA catheter.
Yeah, thank you.
She said you cannot extrapolate in clinical settings. As you said,
No.
it is subjective. You are well versed with ultrasonography and you are able to measure all this E by A and E prime by E prime and E by E prime. All these things you are well versed with calculation of ejection fraction, diastolic dysfunction, systolic dysfunction, right ventricular failure and left ventricular failure. If you are well versed with ultrasound and bedside, why can't we extrapolate for weaning?
No, we can extrapolate.
Sure,
Yeah.
Sure, sir.
Yeah, definitely it is subjective, but you should be very you should be very good in using ultrasound. Regular practice only will make you more perfect.
Correct, sir.
Yeah. As Srinivas said, you cannot replace with the PA catheter. Who is using all these techniques in bedside? Srinivas, Jakina or Satish? Are you using?
No, ultrasound wise we are illiterate.
Not like illiterate, Nandrini. అంటే diaphragm thickness, what she explained, and other things. You are pulmonary edema or ARDS, you are putting a probe no immediately once patient is difficult for weaning. చేస్తున్నాం కదా.
The same thing. No, we are not well versed and we are also not confident of what we are doing. Definitely, I have to accept that my setback.
David sir.
David
sir. Okay. Nice class, Dr. Sinju. So the issue is when the patient is having a failure of SBT, usually we suddenly do it. But ultimately, what we need to do is we need to measure all these things before putting on SBT or during the SBT. Yeah, we have to look into it and then we have to put on a SBT before SBT and then we have to put it on it. So that actually when the patient is having failure, we are looking into all these things. Definitely, right. Sir.
Agreed,
sir. Yes, sir. As you said, sir, it should be a daily protocol, sir. As you said, it should be a daily protocol. Not a single point thing will give us an information.
Yes.
From day one, patient might be having a grade 2 diastolic failure on day one. So if you are assessing grade 2 diastolic failure after failure of SBT, it won't make any meaning. So it is when you are having a grade 1 on day 1 and grade 2, it has worsened on SBT, then only we can make a difference and then we can understand that there is worsening of LA pressure.
And PA catheter has its own disadvantage. So still we say it's a gold standard?
A gold standard is always invasive, sir. Still the gold standard is invasive.
At least we need to have some comparison, no? So far the best studied is PA catheter, so we just compare with that. Not that everybody should have a PA catheter.
Okay.
As Srinivas Jakna said, once you do all the tests and then start weaning failure, if you as per your ultrasound measurements, patient is not fit for weaning, then you start weaning. If your patient is able to wean, that means your measurements are not correct. If patient is unable to wean, your measurements are correct. So one way you can use that like this.
Sir, atla undadu sir, because
అంటే సబ్జెక్ట్ అంటున్నారు కదన్నా అంటే మన పేషెంట్ కరెక్టా రాంగ్ అన్న తెలుసుకోవడానికి
the patient can have, we see even the diaphragmatic expansion may not be, shortening may not be so much. The whatever it is, she has mentioned around 13 millimeters or 14 millimeter, more than 13 millimeters. But sometimes patients can be weanable, and over the time they may have a failure or they may improve. That actually we need to look into very cautiously those patients, but we should attempt weaning that patient.
David,
every study says the probability only, not the surety or assurance. Probably every study speaks about the probability.
Madam, cheppandi.
I think diaphragmatic thickness we should be able to do. Is it? It may not be that difficult to do. Is it, Srinivas?
Easier, madam. Easier, madam.
Not difficult. It is not about the difficulty level, but about the chances of like positivity or negativity. What you are.
That's true.
Success.
Yeah, I think anyway we do for checking B lines, effusions, aeration problem, those things we know, but along with that, a diaphragmatic thickness also should be able to do. And VTI, some of us are very good, like Srinivas does regularly. So I think these combinations should be enough to predict the easiness or difficulty of weaning, right? But as everybody said, we are using all these. Once we fail or difficult weaning, then only we are doing. Like if we do like regularly, probably even before we try weaning process, maybe we'll know whether it's going to be easy or difficult. And we can prognosticate the relatives also. We can counsel it's going to be prolonged weaning or may need a trachea or all those things, right?
Yes, madam.
I think the biggest hindrance is time. It takes a lot of time, especially when you do it in the beginning, to do an overall ultrasound assessment. And I think that's the reason it is difficult for us to do. For example, if we have, say, on an average 7-10 patients on ventilation, then at least 3 or 4 might need a detailed assessment every day. And I have seen that it takes almost about 30-35 minutes per patient to do a detailed evaluation, especially when you begin. Srinivas, how much time do you take on an average?
10 minutes, max 10 minutes.
Yeah, I think that happens with time, right? I mean, you've been doing it for years. I think that's the hindrance. If you keep doing it, that's the reason we sort of back off from it, I think, because each case takes so much time in the beginning. I think we have to be patient and keep doing it. Thank you.
Okay, thank you all. Due to lack of time, we will conclude the session. Thank you very much, Sinju. Madam, can you talk on reflect, conclude session? Madam?
David, I think all others are also in this group. So all who are included in Reflect, we are planning to have a meeting on Sunday. So Mohan sir will put the link. We'll join and discuss about all those things and about workshop and about the Reflect and chairpersons and all those also we have to decide. So Sunday, please check your messages for link and we'll join the Zoom meeting on Saturday. Okay?
Yeah, and also request all the Morton team to register for this workshop, and both workshop and CME, and tell all your friends to do registration for this. Thank you. Thank you, Sinju and Monanga, for a nice active presentation. Thank you all for your active participation. Thank you.
Thank you, sir.
Close the session.